Okay, good morning. I want to call to order the joint informational hearing of the Senate Public Employment and Retirement Committee and the Assembly Public Employees Retirement and Social Security Committee. I'm pleased to have everyone here. And I want to thank our guest speakers and members of the audience for our joint informational hearing today that we're doing on policy implications of mandating high deductible plans in PEMCA. Today we'll be discussing the policy implications of mandating CalPERS to include one or more high-deductible health care plans in the Public Employee Medical and Hospital Care Act, or PEMCA, which is the health care program administered by CalPERS for state employees and retirees and other local contracting public employers and their employees and retirees. This year's governor's budget included a proposal to mandate inclusion of one or more high-deductible plans in PEMCA. While budget hearings will focus specifically on the proposal from a budget perspective, we believe that the potential impact of including high-deductible plans in PEMCA warrants a thoughtful and detailed look at the policy implications of doing so. PEMCA currently provides health care plans for the state over 1,100 public employees and their employers and their employees and retirees, covering over 1.3 million lives. CalPERS offers over a dozen traditional health care plan options. And so today we'll be exploring the impact of adding high deductible plans into this mix and how doing so would potentially impact the other plans in PEMCA and the employees and retirees who receive health care under PEMCA. Certainly, high deductible plans have been touted as a tool to reduce health care costs by making beneficiaries more prudent purchasers of health care. We'll examine the research on high deductible plans and their impact on health care utilization and cost. It's also important to understand how different plan designs may result in increased or decreased adverse selection, and thereby ultimately influence access and quality for all state employees and retirees. We're particularly interested in the long-term impact of high-deductible plans on prevention and chronic disease care. Certainly, chronic disease accounts for 70 to 80% of our health care spending, and that percentage is even higher for seniors and retirees. Thus, it becomes even more important in light of the governor's intention to address funding for retiree health, because changes in health care utilization by employees now may actually impact retiree health costs in the future. So, with that, let's see, I don't see any other coming minutes. Okay, so I have no colleagues to recognize with us today at the moment. When they come in, we will. So with that, I'm pleased to now invite my fellow chair on the Assembly side, Mr. Bonta, to make some introductory remarks, and thank you so much.
Thank you, Dr. Pan. Mr. Chair, I'm pleased to be able to join everyone today for the joint informational hearing, and just want to welcome everyone and who's speaking on today's agenda and attending in the audience. Thank you for being here. It's a very important topic, and I look forward to today's discussion. As chair of both the PERS and the Health Committee in the Assembly, the issue is of particular importance to me that we're discussing today. While I'm very interested in looking at ways to contain skyrocketing healthcare costs, we must be sure that any proposal to deal with those skyrocketing costs actually reduces the cost of healthcare rather than simply shifting the cost from employers to employees. Additionally, because CalPERS offers a variety of different healthcare options, we must be sure that any attempt to mandate a high deductible plan into that menu of options doesn't result in adverse selection, where individuals who don't need healthcare today migrate to the high deductible plan only to move to one of the other traditional plans when their health needs change. Finally, our primary concern should be how can we achieve good health outcomes for our public employees. We want to create situations where people get the health care they need early in their illnesses rather than waiting to seek medical care once the situation has become critical. I look forward to today's discussion and thank everyone again here for joining us. With that, I'll turn it back over to Dr. Pan.
Thank you, Senator Bonta. So we're very excited to begin with our first panel. We have Maribeth Shannon from the California Healthcare Foundation. Welcome. And also Dr. Niraj Sood, hopefully I can pronounce that correctly, from the USC Schaefer Center. And I understand you're going to be busy today. You're presenting this afternoon as well. So welcome. Actually, Ms. Shannon, do you want to begin?
Great. Thank you very much. So though high-deductible health plans have spread rapidly in other parts of the country, California has been slower to adopt them. Of those Californians with employer-sponsored health insurance, the majority, 53%, continue to be covered through HMO plans like Kaiser. As of our most recent survey of employers that was released in 2014, just 6% of Californians are enrolled in high-deductible plans with savings options, such as the health savings account being discussed for CalPERS. So these plans continue to be relatively new for us. With funding from the California Healthcare Foundation and the Robert Wood Johnson Foundation, the RAND Corporation conducted the largest ever study of the effects of high-deductible health plans and consumer use of them. Dr. Sood was part of the study team, and he can provide much more detail on the particulars, as well as highlight other research that he's done. But in funding this study, what was it that we had hoped to learn? First, the question of, do high-deductible plans save money? The RAND team did project the equivalent of about a 4% decline in total health spending for the under 65 population if 50% of the overall population was enrolled in high-deductible plans. But how do those savings occur, and were the participants being better shoppers? Almost all of the savings were derived from participants deferring care. Specifically, the study found that 2/3 of the savings came from fewer episodes of care, and the additional third from fewer services occurred during those episodes. This is compared to their immediate prior health care use when they were in a traditional plan. So is that good or bad? Well, it clearly depends on whether the services being deferred are of marginal value or if they're important. Unfortunately, it seems that participants had a hard time differentiating between beneficial and non-beneficial care. In addition to skipping an office visit when they came down with a cold, members would also choose not to fill needed prescriptions. Others chose to delay or cancel recommended follow-up care. Even preventive services that were covered at 100% were deferred. We also wanted to know if these patterns were different for those with low incomes or with chronic disease. So we studied those populations separately, and unfortunately the patterns are the same. There was no statistical difference found, and so with greater health care needs, those patients were no better at choosing beneficial versus non-beneficial care. So for example, tests of hemoglobin A1C, which is an important test for people with diabetes, declined 4% in the first year following enrollment. So patients chose to have that test done less frequently. Because these plans are so new, the long-term impact of this avoided care is unknown. However, the potential downside of skipping care could be more severe for fragile populations. Skipping a follow-up appointment could cause a patient to relapse or end up back in the hospital, and the pattern of consumers having difficulty knowing the difference between beneficial and non-beneficial care is problematic. Another projected value of high-deductible health plans that we wanted to test was whether consumers would be better shoppers when they were using their own money from a health savings account. Despite efforts to provide shopping tools from health plans or others that offer high-deductible plans, there's little evidence that consumers are using them to find cost-effective providers. In another report, also done by Dr. Sood, they looked at the same study population but looked at prices and whether or not people were shopping for care, and there was very little evidence. People perhaps would choose generic prescriptions over brand-name drugs but didn't have material other differences other than a small change in office visits. So though the potential of consumer-directed health plans is still there, the reality is that there are significant gaps in the tools that consumers will use to find meaningful cost and quality information. So better support is needed to help patients understand their benefits, what services apply toward the deductible, how out-of-network services are priced, and when and how to submit claims. So if those tools are in place, it may be easier. We may have different findings, but the initial studies still reflect people had difficulty choosing the right options. And then a final consideration is the impact of offering a high-deductible plan alongside traditional plans. According to the Agency for Healthcare Research and Quality, 50% of the population consumes just 3% of total healthcare costs. The other half of the population consumes the remaining 97%. When a high-deductible plan is offered alongside other kinds of plans, it's often the healthiest employees who choose that coverage. In the RAND study, those who elected high-deductible health plans had health risk profiles that projected 25% lower health care spending. This, of course, is logical. Healthier people with less expectation to use health care services would be more likely to go at financial risk. But the trade-off doesn't work as well for those with significant health issues who may prefer higher premium and greater coverage of health care costs. So if healthy people choose high-deductible plans and sicker people remain in the traditional plans, it creates a spiraling cost in those other plans and has the potential of driving up premiums on that side. So there are other cost containment options in plans. Most of this study was done prior to the implementation of a lot of the elements of the Affordable Care Act. And so what we've seen are increasing changes in traditional plans, things that move payment mechanisms toward quality rather than quantity, the use of narrow networks which limit consumer access to certain providers, ideally the best value providers and not just the lowest cost, and increased incentives for hospitals and physicians to work together to hold down the cost of care, such as accountable care organizations. So because our study was done a few years ago, we're unable to compare how high deductible plans, how they compare from a cost to traditional plans that are being offered now, which are slightly different than the plans in place at the time. So with better tools, can we turn participants of high deductible plans into better shoppers, or will poorly informed choices continue to sort of defer the benefits that we might see with a high deductible plan? And we don't have long-term studies, so we don't know what the long-term effect of deferring care would be on some of these patients. So clearly more research needs to be done. But I'd like to turn it over to Dr. Sood, who can provide more details on this study and others.
Okay, thank you. So we'll take the questions at the end of the panel with Dr. Sood. Welcome.
Thank you. So it's a pleasure to be here, and I'm going to update some of the findings that Mary Beth talked about. And so I first want to just acknowledge that we initially got funding from the California Healthcare Foundation and the Robert Wood Johnson Foundation. We collected data from about 54 large employers. And then later I got a grant from the National Institutes of Health to look at the longer-term aspects of enrolling in high-deductible health plans. So I'm going to talk about what are high-deductible health plans, how they affect healthcare costs, both in the short run as well as in the long run, what are the implications for adverse selection or plan offerings, what are the effects on consumer behavior, and I'm going to talk about use of preventive care, use of prescription drugs, especially for chronic illnesses like statins, use of emergency rooms and inpatient costs. The fear is that if people cut down on needed care, this will show up as higher ER costs or higher inpatient costs in the future. And I'm going to talk about price shopping or value shopping, that are people being more prudent, as was mentioned earlier. So high deductible health plans basically have two features. You have a high deductible, so you pay the first $2,000 to $3,000 of healthcare costs out of your pocket. And they also have a tax-free health savings account, and you can use the account money to pay for healthcare on a tax-free basis. And both enrollees and employers can make contributions to these accounts. So the implications for out-of-pocket costs are consumers may pay more out-of-pocket for healthcare before insurance kind of kicks in and begins to pay for care. But at the same time, these plans have lower premiums. So if you are relatively healthy, then this is a good deal for you because you get the low premiums and you're not hit with the high deductible. But if you are not healthy, then this is not a great deal for you because the high out-of-pocket costs initially would outweigh the premium savings you would get. So these plans are becoming increasingly popular. This is data from a national survey done by Kaiser, and you can see that in 2005, about 8% of large employers offered such plans, and by 2013, 43% offered such plans. If you look at enrollment, there's a similar pattern with a five-fold growth. So in 2006, only 4% of employees had high deductible health plans. And in 2013, about 20% of employees have high deductible health plans. This is data from the same national survey conducted by Kaiser and HRET. So we find clear evidence that the high deductible health plans reduce healthcare costs. So what we find is if you enroll in a high deductible health plan in year one, your costs are about 22% lower compared to enrolling in a traditional plan which has a low deductible. And now we've kind of followed this cohort over time, and the magnitude of the savings decrease, but they're still sizable savings. So by year three, there's still if you project about an 8.5% reduction in costs for those who enroll in plans. You'll have to multiply this by the fraction of people who enroll in plans to get the overall cost savings. So we also find evidence that healthier patients select into high deductible health plans, and because of adverse selection, so if the healthy people move out of traditional plans and go into high deductible plans, the premiums for the traditional plan are going to rise. So our estimate is that people who choose high deductible health plans in the year prior to enrollment, their costs were about 25% lower than people who did not choose high deductible health plans. So this is the favorable selection, the healthy people choosing high deductible health plans. And if you kind of assume about a 20% enrollment or a 20% enrollment in high deductible health plans, what this means is about a 5%, roughly 5% increase in premiums for the traditional plan, just because of offering a high deductible health plan. But this favorable selection into high deductible health plans can be mitigated by two things. The first thing is you could just offer higher employer contributions to the health savings account. So that is effectively reducing the deductible. If your employer pays $800 or $1,000 into the high deductible plan, then it will incentivize the relatively unhealthy people also to switch to a high deductible health plan, because you're effectively making the plan more generous. The other thing you could do is you could increase premium savings from enrolling in a high deductible health plan. So if the high deductible health plan has a really low premium, that is going to incentivize more people to choose that plan, and that will reduce the amount of adverse selection. So initially, when we did the study and we just looked at data 1 year after enrolling in a high deductible health plan, what we found was there was a modest decline in the use of preventive care, such as cancer screenings and the blood test for diabetes. But now when we've looked at cancer screenings over a 3-year period, what we find is that there is little difference between enrollees in high deductible health plans versus enrollees in traditional plans in terms of the rate of rates of getting mammograms, colonoscopies, and an FOB test. And typical guidelines actually recommend these tests not every year. For example, a mammogram is, I think, every 3 years, and a colonoscopy is every 10 years. So we find basically little evidence of a change in use in preventive care over the long run, even though in the first year we did find a decrease in these use of preventive services. We find that high deductible health plans reduce the use of medications for chronic conditions. So just taking a step back, if you face a high deductible, there are 3 things you could do. The one smart thing to do would be to stock up on your drugs. So buy drugs in December because you know in January I'm going to be in a high deductible health plan and the cost of drugs is going to go up. So that's a smart thing to do. The other thing to do would be to switch to a generic or a low-cost option. That's again a smart thing to do to save healthcare costs. And the third thing, which is not so smart, is to basically just stop taking your drugs or reduce use of drugs outright. And basically what we find is that most of the savings that come from high deductible health plans in terms of drug costs come from outright reductions in use. A very small fraction, we do find stocking behavior and we do find switching to generics, but if you look at the big picture, most of the savings are coming from reduction in chronic drug use. So to give you a number, we find about a 7.5% reduction in use of chronic drugs. One option is that some employers, what they do is they realize the importance of medications for chronic illness or prescription drugs more generally, and they carve out that benefit, which means the deductible does not apply for drugs. So when an employer does that, it reduces the effects, but it doesn't eliminate the effect. So it reduces the effect by about 50%, because if you face a high deductible, you still face a high cost of going to the doctor and getting your prescriptions. So we kind of see about, instead of a 7.5% decrease, about a 3 to 4% decrease in use of medications for chronic illness. We also looked at what happens to ER costs and inpatient costs, and over, again, a 3-year period after enrolling in a high deductible plan, and we basically find no effect on ER or inpatient costs. They don't go up or they don't go down. They kind of remain more or less the same. So then the final thing we kind of looked at is that if high deductible health plans are making consumers more prudent, then we should expect them to shop for healthcare. So go to a cheaper cost MRI provider or a cheaper cost lab and so on. And basically what we find is that there is little or no evidence of increased price shopping for high deductible health plan enrollees. So this data shows the fraction of enrollees in a traditional plan for the different services we looked at, office visits, pelvic ultrasounds, mammogram, and a chest x-ray, going to low-cost providers. And when we look at this market share of low-cost providers and high-deductible health plans, it's more or less the same. The only place where we find some evidence of price shopping is for office visits. So in a recent study published in JAMA, I looked at what happens to price shopping behavior when people have access to online tools for price shopping. So these tools are, in some sense, like Amazon, or a typical shopping website where you can put in your zip code and it will tell you all the doctors or all the providers within a 5-mile radius, and it will show you the prices of those providers. So what we found is that when people use these online tools, they actually do save money. So we found about savings of about 14% for lab tests and savings of about 13% for advanced imaging. We find very small savings, even though they were statistically significant for office visits, about 1%. So in conclusion, there are several kind of pros of high deductible health plans. First is this is kind of a lot of employers are using this strategy to control healthcare costs. There is clear evidence that lower healthcare costs over a 3-year period that we looked at. There is no evidence of the downside of increase in ER costs or inpatient costs. There is little or no evidence over the long run of a decline in preventive care visits, although we saw some effect in year 1. But on the flip side, what are the cons of high deductible health plans? We do see that there will be a modest increase in premiums for traditional plans due to favorable selection. There's clear evidence that individuals who enroll in these plans are healthier. We do find a clear evidence of reduction in medications for chronic illness, which might have long-term implications for health as well as healthcare costs. We also find little or no evidence of price shopping. So the cons can be mitigated by higher employer contributions to health savings account. This will kind of discourage favorable selection or adverse selection in traditional plans, and by increasing the premium savings of enrolling in high deductible plans, and carving out the drug benefits to reduce the con of reduction in chronic medication use. And finally, I think an important thing which Mary Beth also talked about, offering online tools to engage consumers to enable them to make prudent or value-based decisions. That just changing consumer incentives by increasing the deductible is not enough. What we really need to do is outreach for individuals to understand their benefit and then give them really the tools to make better decisions. Thank you.
Okay, thank you. Thanks very much. I just want to recognize some of our committee members who have joined us today, Senator Bell and Senator Morrell. Welcome. And I see some Member Waldron. Thank you as well. So I'm going to open up for questions. Questions from members. Senator Bell.
I had a question about the universe of people that you look at when you look at the pros and cons. And have you examined how this impacts retirees specifically? Say this proposal went to the issue of retirees versus employees. Are you looking at, as a universe, employees, active employees, retirees, or both, or when you studied this particular aspect?
So the data came from 54 large employers, and most of the data comes from active full-time employees. We did not do a separate study. I think some of these employers offered retiree healthcare benefits, but we did not do a separate study where we compared effects for retirees versus effects for below 65. So I would say these findings are representative for the below 65 population.
And then what is the demographic profile of those individuals in those retirement plans? Are they, do you have an idea of what the average age would be?
In the retirement plans?
In the plans that were studied.
In the plans that were studied, it's basically
average age.
The average age, I don't have the number on top of my head, but it would be somewhere in the mid-30s.
Mid-30s, okay.
Yeah. So these are basically active employees of large employers.
Okay. Have you studied Have you studied retirees specifically?
We did not study retirees as a separate population.
Okay.
There was one aspect of the study that would help, though, because you did look at those with low income and chronic conditions separately, which might be more representative of the kind of population you'd find with retirees, that you'd find people with more chronic conditions. And there were no significant differences between the populations. They tended to defer beneficial care at the same rate the active employees or the healthier employees did.
Yes, and the other question would be, in terms of health outcomes, we always want to evaluate plans on their performance, and not in terms of cost, that's important, but also health outcomes. When you evaluate plans in terms of health outcomes, there's some common evaluation processes that are done, comparing apples to apples, if you want to call it that. What kind of outcome evaluation is done in this model? Do you use HEDIS, the full HEDIS evaluation process, or what is your evaluation process for that?
So these studies rely on health insurance claims data from these large employers.
Oh, okay.
So we don't directly observe health outcomes that would require electronic medical records or similar data. So our proxies.
Okay, so it's
So our proxies for these outcomes were to look at services which we think are high value, like use of preventive services or use of drugs for statins, antidiabetic drugs, and so on, and also to look at some of the potential adverse effects like increase in ER use or increase in inpatient costs, because those are indicators of something going wrong.
Yeah, but I'm looking, when I say health outcomes, I don't necessarily mean cost and drug use, I mean outcomes. I mean,
Yes,
health,
so we can
health outcomes.
Right. So
How's that evaluated?
it wasn't in this study. We didn't look at the HEDIS measures.
Talk about money, insurance
But
claims.
there were
but
some
that's not
things like a HEDIS measure is the percentage of the population that's actually receiving things like an A1C test.
Yeah, right, yeah.
And those things did decline. So one might extrapolate that the HEDIS measures perhaps could go down in these populations in the first years, but as Dr. Sudin mentioned, in subsequent years, people seem to be going back and getting those preventative services that are measured by HEDIS, so maybe it rebounds in future years.
Usually what you look at health outcomes, you're trying to evaluate whether health gets better, because unless if health doesn't get better, or if it's has other negative effects, you're really talking about cost shifts rather than cost savings. Okay, so I'm particularly interested in health outcomes. If that could be,
Yeah, and
Mr. Chairman.
I would argue we would need a much longer-term study to really see that effect.
Yeah. Okay. So that's why I'm a little bit.
Yeah, we don't
I
have
think
that.
that probably is something that needs to be looked at maybe a little more closely. Thank you.
Thank you. Other questions? Just Senator Balta.
Thank you. Can you provide some additional clarification, maybe some amplification regarding your slide on page 7, HDHPs reduce healthcare costs? And just help me understand what factors went into costs and whose costs they are. Are these employer costs, employee costs? Is it spending for the employee?
Yes.
Can you just help me understand that a little bit more?
Sure. So these are total healthcare costs, which is the addition of employer and employee costs. So this is not just looking at what happens out of pocket for the employee. It's not looking at what happens for the employer. When you add all the healthcare costs, so this is the total amount of money that was spent on healthcare. And this is comparing individuals in high deductible health plans compared to individuals in low deduct or in traditional health plans. And the models adjust for a variety of factors. So they adjust for the fact that individuals in high deductible health plans were healthier, and even before they enrolled in these high deductible health plans, they are typically younger, they are more likely to be educated, and so on. So it kind of adjusts for underlying differences in demographics as well as health.
Okay, and do you have some conclusions as to what led to those reduced costs? Is it and where does reduced utilization play a role?
So about 2/3 of the reduction comes from reduced utilization, specifically reduced outpatient care and reduced use of prescription drugs. And about 1/3 of the reduction in costs comes from reduction in costs given an episode of care. So you enter a hospital and you just spend less money, or you go for a you have a healthcare episode, you just spend less money on that episode. So, but we don't find over the long run, over the 3-year period, any savings coming from reductions in ER costs or reductions in inpatient costs. So most of these savings are being driven by reductions in outpatient care.
Thank you.
Any other questions? Okay, I have a few questions myself, so thank you so much for being here. So as you were looking at reductions costs, and I guess you mentioned that the average age was in the mid-30s to Senator Bell. So this is actually a fairly young population, because if you took everyone under 65, you think about the workforce, right? You enter the workforce usually somewhere in your mid-20s, unless you happen to be unless you get overly educated, then you a little later. And then, 65, well, people retire 60, 65. So the fact that skewed to the 30s is actually kind of interesting, because that skews pretty young. You would think the average would be somewhere in the 40s, but if you were looking across the population. But did you take a particular look at conditions like diabetes and asthma, people with those conditions? I mean, so for example, high blood pressure, you look for 3 years. The sequelae of not taking your high blood pressure medication, and especially with a younger population, probably isn't going to show up in 3 years, right? And you mentioned that even the colonoscopies and so forth, which actually, by the way, you don't start doing this till you're 50, unless I got the recommendations wrong. You're not going to, and I realize, that's always a limitation of any study. How long do you follow people? That you're not going to see it. But for example, something like asthma or diabetes, where if you don't get your hemoglobin A1C, well, there's certainly longer-term impacts like neuropathy and other types of things. There are sometimes some more immediate, and same with asthma. In fact, there's been studies showing that reducing cost sharing in asthma care actually induces people to, while they take more meds, actually reduces the costs, because they utilize. So yes, you showed there's no ER difference, but I wonder if you were looking at specific chronic conditions that had more of an acute impact, to look specifically. It's just as a way to look at, because some of the other ones are longer, so we won't know for 10, 15, maybe even 20. Well, actually, with this population, even longer. If you're not taking your statins or you're not taking high blood pressure medication, that stroke that you could have averted, that's not going to show up in a 3-year study. So I don't know if but looking at conditions that were more acute, where the impact would be quicker, that if you didn't take your controller med for your asthma, you're more likely to end up in the ER probably within months or something like that. Did you take a look at those and see if there was an impact there, both in terms of their use of medication for these populations, and then of course ER hospitalizations for these subsegments?